Welcome everyone. Before we begin, I'd like to acknowledge the lands where I live and work. The traditional owners are the Wurundjeri people of the Kulin Nation. I pay my respects to elders past and present. I acknowledge that the treaty that's been made official just in the last few days here in the Kulin Nation is only a very small step on what is a very long and important path to full reconciliation and full recognition of Aboriginal sovereignty and First Nations sovereignty. So I extend my
I think it'll be
respect to the traditional owners of all of the lands where the people in this webinar are today, and fully recognise that this always was and always will be Aboriginal land. So welcome. You are here at the final report launch and website launch for the ARC Future Fellowship and ARC Centre of Excellence for Automated Decision Making and Societies funded mega project, digital and data capabilities for sexual and reproductive health. We can't put all the words on the blurb every time. The original title also included policy and practice, which we'll be talking about today, but I won't go through the original title. The research team for the central project was myself, Dr. Sam Mannix, who'll be presenting with us today, and also Caitlin Learmonth, who's the PhD candidate on the project and has done extraordinary work. And we'll be talking about the research that we've done and the website that we created as part of this project, and also, I guess, what we see as some of the future work that's necessary in the space of digital and data capability building for the sexual and reproductive health sector. But we also have a great opportunity today to hear from a number of practitioners, because this was a deliberately interdisciplinary project. I am a media and communications researcher, but with a history of collaborating with the sexual and reproductive health sector, and also with sexuality educators who work in secondary school spaces. But a lot of the work that I've done over the years has been about what might be termed sexual expression in media. So practices like selfies and sexting, or the use of dating apps and how that works in a kind of socio-technical sense, and how people learn about sexuality and gender through those practices, but also what it means for their sexual health and well-being as they engage in digital technologies, and how that can support identity and well-being, and how also it can be seen as a kind of barrier to a kind of strong sense of health and well-being in terms of sexuality, and in terms of other aspects of the self and of identity. And obviously, when you do this kind of research, you're often invited to talk to your collaborators or your colleagues in health, and you're asked questions about the digital space and how the workforce can better engage with the space of the digital, particularly where they're working with young adults. And I should say this project specifically focuses on young adults. It's a project focusing on the practices of 18 to 29-year-olds. And I really adopted that focus because it seemed to me that, one, I was getting as many questions from people who worked with adults as I was from people who were working with younger people, and it seemed like this was an important space for workforce collaboration and workforce development, but also because we know from past research conducted at Arches, and one of the co-authors of that research, Natalie Hendry, is here with us today in the webinar, that even though young people are considered to be a priority population for sexual and reproductive health in Australia, most of the funds and most of the research is conducted with school-age young people, and there is less research and less focus on the specific needs and practices of young adults, that is 18 to 29-year-olds. Now the category of youth has been contracted down to 18 to 24, which I think is probably more appropriate given the things that the kind of health funders are trying to focus resources on. But over 18s are a very different age group to under 18s. They are at work, they are at university, they are undertaking apprenticeships, they are traveling, backpacking, going to festivals, they're autonomous, they don't live with their parents, they have their own Medicare card, they are experimenting with sex and sexuality in ways that younger people aren't. It's no longer illegal for them to exchange nude images of themselves consensually, so we don't need to debate whether or not those images are pornographic in the same way that we do when we talk about working with younger people. So there are a whole lot of issues that I thought it would be really valuable to tease out in relation to learning more about young people's practices and specifically what they say they want health professionals to know about those practices and how they want health professionals to respond to their digital practices in clinical settings, but also how they'd like to receive health promotion content. And I also felt very drawn to exploring the notion of digital literacy in this context, because often when I was talking with professionals, whether they were educators or whether they were clinicians, I would be asked if I thought digital literacy was the right way to address some of the issues that people were concerned about with digital technologies, with social platforms, with dating apps, with menstrual trackers, these kinds of things. And I wasn't always certain what the term digital literacy actually meant in a health setting, or whether we were just talking about the digital literacy of a health consumer and whether it didn't matter what digital literacy meant in a health setting. And so this is the kind of topic that I set out to explore with this project, but also to think about, okay, what does digital literacy and data literacy, because this was a really important area of research here at Swinburne with my colleague, Professor Anthony McCosker, and also in the work I was doing in the Centre of Excellence for Automated Decision Making. What does data literacy and data capability mean in this space? And that question became increasingly important as AI became a very big issue in health, and AI-driven tools and technologies obviously are at their core data-driven tools and technologies. So you'll hear about what we actually did and why we did it, and the ways we designed resources as part of the knowledge translation work from this project, and why we designed them the way we did a little later on in the seminar. But as I said, the thing that I'm really excited about in this project and in this launch is that all of the research we've done over the past 4 years has been very much engaged with the health sector, really trying to listen to and be clear that we understand the needs and interests of the health sector, whether it's the space of digital health or public health or HIV health promotion, or any of the areas that we've been engaging with and partnering with. And so what's really been important to me is that we center the quote unquote problems of digital health as the problems that the health sector perceives. Because one of the things that's really interesting to me about interdisciplinary research is it's so often very translational, and it's very much about trying to put down what it is you think you already know about a problem and see it from the perspective of your colleague who has a very different disciplinary side of expertise and a very different set of interests in terms of their research. So with all of that preamble, it is an absolute delight to introduce our first guest today from the sector, Dr. Muyi Iyamu, who is a colleague from the School of Population and Public Health at the University of British Columbia. I really love Muyi's work and the work of his colleagues, and I've been following it for quite a while, and we've had amazing conversations over the course of this project that I'm hugely grateful for. Muyi's research focuses on using implementation science, design thinking, and evaluation methods to improve digital health programs, making healthcare more accessible and equitable. He's collaborated with the BC Centre for Disease Control's Digital and Sexual Health Initiative to enhance sexual health services like Get Checked Online. And for those who are interested in digital sexual health testing, the Get Checked Online evaluation has recently been published. It's really a very interesting read. Muyi trained as a physician at the University of Benin, Nigeria, and earned his PhD at the University of British Columbia, and he's led research in multiple settings, including HIV/AIDS control programs funded by PEPFAR in Nigeria. His postdoc focuses on ensuring the sustainable implementation of digital public health interventions like Get Checked Online. Thanks so much for joining us, Muyi, and apologies for butchering your name when I introduced you.
No, thank you. And like I've said multiple times, it's always a pleasure talking with you.
So great. Thank you. So can we take the slides down? Awesome. Thank you. So I have some scripted questions for Muyi, and I've also invited him to ask me questions. So we're going to have a little bit of back and forth, but he may interject and ask me a follow-up question if he so chooses. So Muyi, one of the things I've really enjoyed about your work is the way that you draw such an important distinction, I think, between digital health on one hand and digital public health on the other hand. And this had really strong resonances for me with the ways that my Centre of Excellence colleague Zara Stardust conceptualized public interest sex tech in our project to distinguish the kinds of sex tech that we were interested in talking about and conceptualizing from a more kind of Silicon Valley startup style sex tech narrative. Can you tell us a bit about how you define digital public health and why you define it the way you do?
Yeah, I can start. But before I do, is it okay if I acknowledge the lands on which I call
Yes,
from today?
please.
The unceded traditional and ancestral territories of the Coast Salish people, including the Musqueam, Squamish, and Tsleil-Waututh nations. And I'm constantly grateful for the beautiful land and the stewardship that has allowed me to enjoy it today. And now to your question, this is a question that we probably encountered for the first time, I want to say in 2019, when as a group, my team at the BC Center for Disease Control was really thinking very deeply about what we want to do with digital within the public health space and how that might be in itself different from how the general conception of digital health would look like. And so we started off by doing at the time a scoping review, just trying to understand what the definitions of digital public health were. And that led us to clarifying that, first identifying that there are many different definitions, but over time through consultations nationally, clarifying a definition and making it distinct from digital health. So we define digital public health as the use of digital technologies to transform public health functions in people-centered ways that optimize health outcomes for all. Now, this is very specific definitions that really emphasize the role of connecting with communities that we hope to serve with public health, but doing it at a transformational level, not just layering on digital to the existing services, but taking a step back to rethink how we deliver public health services as a whole and the ecosystems that we use to deliver it. Now, in these definitions, we emphasize a number of things. One would be the deeply transdisciplinary nature of digital public health, in that it is forcing us to navigate spaces we are not routinely used to navigating. So engaging with the computer scientists, the social scientists, the information scientists, in different ways, leveraging technology as a common force for good in this space. The other thing is that we are really focused on equity. Now, while digital health applies digital technologies at the patient provider interface to facilitate access to care, equity is sort of a secondary goal. The goal is your responsibility as a provider or a clinician to each patient in front of you. As a secondary goal, you might think about equity, but equity forms the basis of the work that we do in digital public health. And so when we think about digital public health systems, we are thinking, how can we reach the most people? How can we reach those at the margins with the interventions that we deliver? And how can we rethink it in a way that people feel connected to the systems, not just in a piecemeal nature?
Thank you so much. And it's such an antithesis to the kind of move fast and break things culture of public health. Sorry, not public health, I should say, of the kind of digital health startup where, yeah, there's often a kind of much more of a market-driven approach as opposed to, as you say, a people-centered approach. And I really appreciate the care that you've taken to define that and distinguish it. Not that there's not a space for startups, but I think that the kind of work that you're interested in doing and we're interested in supporting is a different kind of work, to the sort of the building the marketable tool, the marketable scalable tool. Both of our teams, in different ways, have examined a concept that's still kind of emerging also in public health, which is the digital determinants of health. And I know Sam and I have done much rumination on whether that's the social determinants of health but digital, or whether it's something else distinctly different. Can you tell us a bit about how you're defining the digital determinants of health in your work? Yeah, we might start with that.
Yeah, I don't think you're unique in your confusion about where digital determinants of health, what space it occupies in relation to all the other determinants. For example, the commercial determinants, social determinants, they're all very intertwined. I don't think we've personally sat down to have a formal definition. We've all just gone along with what the literature has said and how it has evolved over time. So, for example, before 2019, before the pandemic specifically, the conversations around the digital determinants of health really focused on the digital divide, and two terms really came to mind at the time. It would be what are the factors that are digitally mediated within the health space that ensure that, or that facilitate or serve as a barrier to people accessing digital or digitally enabled healthcare services.
Mhm.
And the two terms were around digital health literacy and digital access. As time has evolved and with the explosion of technology within the space post-COVID, what we're finding is that there's now a number of different perspectives about how we think about digital determinants of health, not just as the digital divide as in terms of, access to technology and literacy, but even going beyond that to think about trust in technologies, thinking about connectivity and the different levels of connectivities people have, but also the influence of policies, of big companies that determine how the digital environment should run and how those influence our access to health services that are digitally mediated. And so when we think about digital determinants of health, we're thinking about a broad range of factors that act across all the various levels of socio-ecological determinants of health, and how they influence our access to health services that are digitally mediated. And when I say digitally mediated, it's very specific in that we only think about digital health as being apps or websites and platforms that we use to access health services that are digital. But that's not only the case. Even if I were to attend a brick and mortar service today, I need to, for example, book an appointment online. If I were to go access a social health or social service that's connected to my healthcare, I still have to go online or face the horror that is now a phone call to the health system. And so it is digitally mediated to say that we are seeing a very broad footprint of digital across the health systems. And this is only going to continue given all the directions we've seen in strategy documents and so on.
Amazing. Thank you. As I mentioned at the beginning of this project, I started at the beginning of the session, sorry, I started this project kind of asking questions about digital literacy and what is digital literacy when it comes to, not just sexual health, but sexual health services and sexual health workforces. I know you've just done some interesting work with the Dishi group about kind of questioning some assumptions that sexual health researchers might have made in the past about digital health literacy, and the idea that digital health literacy makes people more accepting of digital sexual health tools. And I wonder, I know some of that work's in review right now, so don't share all your good stuff, but I wonder if you could talk a little bit about some of your thoughts on digital literacy and the contradictions you saw in your research.
Thanks for asking that. I think first off, I'm free to talk about it. It's just been accepted, so that's great. The at the time we started looking back at what digital health literacy could mean and how it influences access to some of these services we conceive. I think in the literature there's a lot of rhetoric around the role of digital health literacy in facilitating access to digital services like Get Checked Online, which I primarily work on. The assumption here is that if people have better digital health literacy or digital literacy, however you might want to conceive that, people will be more likely to be accepting and more likely to use some of these services. And so a lot of the recommendations are let's build digital literacies. And, there's recommendations about using library boards and school or educational services to sort of accelerate uptake of these services, but without any specific numbers to it. The other piece we found was that it's very difficult to really, at a granular level, understand what digital health literacy is. There's been many tools that have been developed over time as technologies evolve, but the most popular one still used very widely is the eHeal scale that was developed by Norman and Skinner in, I think, 20 or 2005, so quite an old tool. In our previous work, we had used that to sort of try to understand what digital health literacy means to communities that we serve. So this will be suburban and rural communities that we had expanded Get Checked Online. So in the community survey we did, we just asked people questions using the eHeals tool, which is 8 questions that explore 4 domains but creates one summary score on digital health literacy. So it explores how people are able to access, understand, appraise, and apply digital technology or health information identified online to their health. And so what we did was to do what's called an exploratory and then confirmatory factor analysis on that survey to identify more granular factors or more granular combinations of these questions that we could then create as conceptual ways to understand specific digital health literacies. What we found was interesting. There were 3 main factors. One was around information navigation. So people's skills around being able to identify things online, navigate websites, know where a button is, know where the menu is, and so on and so forth. So sort of the mechanic skills around digital health literacy. The second was around information or critical appraisal. So the skills to understand the information you're identifying, but also identify whether it's needed for you or whether you need to apply the information to your own context. So it's more the critical piece, whether you trust the information that you see. And that's very important in today's digital environment or information environment where, a lot of the information is riddled with mis and disinformation. The third piece was around, sort of the self-efficacy, the confidence to then use the information that you have, identified online. We try to see how these helped us predict awareness and use of Get Checked Online in communities we serve. And predictably, the information navigation skills and confidence in use skills sort of predictably were positively associated with awareness and use of Get Checked Online. But the critical appraisal skills were negatively associated. So the more people had skills for critically reviewing information and assessing whether it's important for them, whether it's credible, the less likely less likely they were to be aware of Get Checked Online, the less likely they were to use Get Checked Online. Now, we're not exactly sure what this means, but we have a couple of hypotheses. We had redone literature reviews to understand, and then we took it to a group of users here and there just to understand at a general level. This is not core research at this time. I'm sure we'll do that in the future, just to understand what they thought. And a number of things came from literature reviews and our consultations. One is that obviously Get Checked Online serves a core group of people who ordinarily may not be served by the health systems, or who have experienced barriers to accessing healthcare. So potentially they may look at the services and not see themselves in that if you're a convenience seeking user for online testing service. But the second piece is around trust and trusting health information online, specifically in situations that are or in conditions affected by stigma. So sexual health, STIs, very stigmatized situations. And what we found was that people had fears of being tracked by ads if they were to search for STIs online, fears that, especially on shared networks, people would be outed to their roommates or colleagues just because they had shared or looked for such information online. So people had trust, issues around some of these services. It also correlated with some of the prior work we had done qualitatively with users who had talked about, just not necessarily trusting systems and wanting to know who's the service for, why is it free, and being reluctant to actually use the service even after they had identified it. So I think these are more areas to think about, but it then raises questions around, again, the policies of companies that run the internet systems, the social media systems, the search services or search engines that we use in providing some of these services online, and how we might need to be critically thinking about their role in mediating access to some of these services that we put up.
Fantastic. Thank you. Really good questions, and that we should be asking and are asking, and a lot more that we could talk about on that specific topic and will in the future, I'm sure. But I just wanted to move on to one last I guess topic that we had planned to talk about today, so that we don't miss it, because I know that your team has been doing work on digital competencies for the sexual health workforce, which is a very strong link with the project that we're doing here. And I know that you see some connections with our project, and maybe some disconnects. So I wonder if you could tell us a little bit more about the digital competencies work you're doing in Canada, and what, if anything, you see, in terms of the role of a kind of the sort of cross-disciplinary social sciencey work that we're doing here as part of that work going forward.
Yeah, I'm happy to. Actually, I was drawn to your digital and data capabilities framework for thinking through some of these competencies, because it's a little more holistic than just thinking about individual level skills. What we were doing at the time, we had partnered with education leads at a couple of schools of public health, a few schools of public health across Canada, including University of Toronto, University of Victoria, and my home, University of British Columbia, just trying to understand how we might think about digital competencies and thinking about how we integrate that into the curriculum, but also the workforce, adapting existing continuing education for the workforce. A number of things come to mind. One of the things we found is the need for what we now term a T-shaped professional. And that means to us the type of professional who probably do better in our current system or our current visioning for digital public health systems. It is a professional who has breadth of knowledge across a bunch of knowledge domains. So for example, if I were to think about myself as a public health practitioner, I have breadth of knowledge across public health, but computer science, human-centered design, maybe a bit of communication. I can understand the lingo. I understand the differences in viewpoints and how we all think from epistemological perspective, how knowledge is created. But then I have depth in one of those fields. And for me, that would be in public health. So I know really how to think about public health interventions, how to think about health promotion and protection, and so on. And I'm able to draw others with my breadth of knowledge into that depth of public health knowledge so that we can share ideas to create effective solutions. And so what we found is that while we can try to create these individuals, there are a number of changes that need to happen concurrently with the systems. So it's not enough to think about training individuals in university or training in continuing education if the health systems they're coming back to working do not facilitate effective action. If there's a lot of friction, which exists today. So I was, in doing sort of a roadshow with focus groups across the country, we found lots of different examples of different isolated systems that don't talk to each other. And even if someone is trained in the most advanced epi skills, he still has to dedicate resourcing to copying data line by line between tables because we have some privacy issue that needs to be sorted out. So we need to be thinking about infrastructure alongside skills in the workforce. And that drew me again to the work that you're doing around just thinking more holistically. It's not just about one person or one group of people, the workforce, but about the systems that the workforce functions within. We also found that we need to be thinking a little more about the basics before going more advanced. So how are we thinking about training people that have depth of knowledge in their own special area? So again, for me, how do I draw on a depth of knowledge in public health before thinking a little more about digital technologies? And I say this because what some of the older, and we found that there was some age discrepancy in the descriptions of this thing. Some of the older practitioners always refer to the need to be recalling people's minds back to core functions and then building on that, the digital, rather than really exploring the digital with all of the enthusiasm, whereas the core of what we do in different areas is still a bit shaky. The final piece was around providing opportunities for specialization and specialized, capabilities within the public health system, whether it's AI systems, digital surveillance, digital communications, just providing opportunities for people to leverage these opportunities to effectively deliver solutions that are needed. But again, it draws me back to the conversations I've had with you around systems. So when I see your own, frameworks and the beautiful circles, it really excites me because this is what we should be thinking about within the health systems.
Amazing. Thank you. And I mean, it's so, the work that we've been doing, is so based on those conversations that I had in health workplaces after doing presentations where people would say, oh yeah, we'd love to be, trying a bit of work on Facebook. That tells you how long ago I started doing this work, when people really thought we need to get onto Facebook. We'd love to do some work on Facebook, but yeah, the firewall in the workplace doesn't let us get on Facebook, and it means I have to use my own phone, and I don't want to do it under my name, and comms wouldn't let me do that, and my manager's afraid of social media anyway, and yeah, all of these infrastructural issues. And in the Everyday Data Cultures project that I worked on with ADM+S colleagues, who are here in the meeting today again, yeah, that story of people being really hamstrung in a workplace trying to work with data because, yeah, they basically were, trying to copy paste lines of text from various closed, bounded, siloed systems back into a single Excel doc so that they could make sense of it. And yeah, how frustrating that work is. And that really is the kind of messy everyday of, the wonderful calls for digital transformation. obviously we could talk and talk, but there are other people here who might also like to talk and ask questions. So I'd like to just open the floor before we thank Muyi, just see if there are any questions, any pressing questions in the group. We will have more time for Q&A at the very end of this session, but if anyone has a very quick question for Muyi. So Alexia's just saying, I think it's a fascinating point that the assumption that building sexual health literacy means more engagement with digital health services. This does not appear to address the critical thinking and agency of users who both decide what or who to trust and to question what these platforms do with their interactions, approaching this with concerns around social risk linked to stigma and data exploitation by platforms actually is the critical thinking we'd like to see. And so this is both a question and a probe for the panel. If how are you thinking about the steps forward around critical literacy, or is that the next stage of research? Like, how do we make trustworthy platforms, I guess?
Probably next stage for research for sure. But I think that even beyond that, there's already the role for advocacy. I think as we in this spaces start to present, I think there's a role for presenting the data to back the fact that even though over time we've started to talk about the role of big tech and how their practices are influencing how we perceive information online and use them, it hasn't necessarily been backed with the research. So many times we could be discounted as having opinions. I think COVID was the first example where we saw at a very large scale the impact that some of these policies have on people's perception of information online and has on health behaviors as a result or as a downstream effect. So I think while we start to think about additional research in this space, thinking about, what role critical literacies play in accessing information, there's a role for advocacy, continued advocacy, leveraging the research that we're already generating to show that if we do not act, then this beautiful technology that we all seem to be very optimistic about. I'm not sure I would like to think about myself as being an optimist these days. If we do not act to protect the interests of the public who uses it or who use it, then at the end of the day, we might lose the very value we saw in it in the first place. And so I constantly advocate for the role of public health practitioners and public health researchers in advocating to, the political class to begin to clamp down. I know that, it's a difficult ask given the power that exists within those organizations, but it is something we have to start doing and doing more strongly.
Thank you. Yeah, and we were just speaking yesterday with our colleagues at NAPWA about the upstream part of public health advocacy and where that might play a part in this work. Thank you again for a great conversation. I'm so grateful you could join us. And I'm so grateful to be continuing our mutual fandom of each other's work and look forward to future collaboration. I am going to now, many thanks from the audience too.
Thank you for having me.
Really interested in your insights here. I'd like to now hand over to Samantha Mannix, who is the postdoc on our project, who is going to chair a roundtable now with some practitioners talking about some of the wicked problems for the sexual and reproductive health sector when it comes to digital health. Thanks, Sam.
Thanks, Kath, and thanks, Muyi. That was incredible and so much to think about. I've been scribbling down notes for the last 20 minutes, so collect my thoughts for our next panel. As Kath said, my name's Samantha Mannix. I'm the postdoc who's been working with Kath for the last almost 4 years. Before doing my PhD looking at young people's digital relationship cultures, I was once upon a time a nurse, Then I worked in health promotion, looking at sexual health in communities, and also worked in the prevention of violence against women. So I'm really excited to be able to chair this practice roundtable, because I think often research can be quite slow and lag behind some of the work that's being done on the ground, and we can learn a lot from asking these questions in very real time. So I'm really excited to have all of these wonderful panelists with us today. We have Amy Tong from the Multicultural Centre for Women's Health, Daniel Reeders from the National Association for People Living with HIV, Jess Wilms from the Western Sydney District Local Health District, and Melanie Bissessor from Melbourne Sexual Health Centre. I'm going to stop the slideshow now so we can see everybody's faces. So as I said, we're going to go around the panel today and consider some of the wicked digital problems that we're currently or sort of experiencing in the sexual health sector, and some of the ones that we may kind of be considering that are emerging within the future. We might start with Amy, who is the Advocacy and Policy Officer at the Multicultural Centre for Women's Health, doing incredible work there. Amy, you can give a bit more background about your work in your response here if you would like, but can you share with us what you see as a wicked problem related to digital and data technologies facing the sexual and reproductive health sector now and into the future?
Thanks, Sam, and thanks for inviting me to speak on this panel. Hi, everyone. My name is Amy, and I'm a Research Advocacy and Policy Officer at the Multicultural Centre for Women's Health, and I'm joining you all from the unceded lands of the Darramaragal people today. I'll just start with a little bit of background about the Multicultural Centre for Women's Health and a little bit about who we are. So we're a national community organisation that's led by and for migrant and refugee women and gender diverse people. And our mission is to essentially advance the health equity of migrants and refugees across Australia. And we do this work through delivering bilingual health education, advocacy, we do research, we do training, as well as capacity building. But to answer your question, Sam, there are so many wicked problems to choose from, but one of the ones that we see at NCWH is how little attention is given to issues of access in conversations around digital and data technologies. There is this sort of prevailing assumption that digital and data technologies will improve health equity for all. But what is often forgotten is that these technologies are frequently, designed around assumptions of English literacy, digital capability, having access to personal digital devices, as well as having stable internet. Yet, preliminary research so far shows that migrant and refugee women in particular face significant challenges to accessing digital devices. And as Muyi so eloquently explained, when equity isn't centered in these conversations, migrant and refugee women and gender diverse people are really unlikely to reap the benefits of digital and data technologies. And we only really have to look back to COVID-19 to really see how these technologies can run the risk of exacerbating health inequity. And so I'll invite you all to cast your minds back to that time that most information about COVID was online and distributed through digital means. And if information was online, most of it was in English. So there was this real gap of timely, multilingual, evidence-based resources about COVID-19 and vaccinations. But as a real result of this gap, migrant refugee women were really left to navigate a complex terrain of health information. And so to address this, our bilingual health educators started to deliver health education about COVID-19 over the phone in women's preferred languages. And when it comes to sexual and reproductive health, we know that these barriers to information still persist. And to meet this need, we have been coordinating the delivery of sexual and reproductive health information and education through the Health in My Language program, so that migrant refugee women continue to have access to clear, trusted information to support their decision-making around their health and well-being. So just to sort of tie it all up, especially as we consider the growing impact of digital and data technologies on sexual and reproductive health, we really need to sort of bring an intersectional lens to these conversations. And while digital and data technologies are great, we also need to address the systemic barriers that currently prevent access to healthcare for migrant and refugee women and gender diverse people, and ensure that these new technologies reduce rather than exacerbate pre-existing health inequity.
Great, thank you, Amy. Such an important reminder to kind of consider the technologies as they're presented to us, and whether we should always just be saying yes to those technologies. And you know, maybe sometimes picking up the phone is the right way, although don't pick up the phone and call me, please. Text messages. I'm going around the Zoom via alphabetical order of first name. So next up we have Daniel Reeders, Senior Project Officer at the National Association of People Living with HIV Australia. Daniel, I know you've encountered quite a specific wicked digital problem as part of your work at NAPWA. Through your digital outreach work, something called brigading. What is brigading and what does it mean for an organisation to be brigaded?
Thanks, Samantha. So I have a more pressing problem, which is Zoom is popping up a message saying my internet connection is unstable. So apologies if I am glitchy as I'm coming through.
It's coming through. Okay.
Fabulous. Brigading is a situation where people who have a grudge against particular communities are using social media sites like Reddit and 4chan to gather together and to share information about our activities in digital sexual health promotion, with the purpose of putting in a whole bunch of spurious complaints about the activities that we're doing. And so I really wanted to highlight this one in particular because I think there's a tendency to assume that when we put up a campaign and it's about HIV, and I've put a really lovely example in a blog post that Caitlin has just kindly shared in the chat, that when we put these campaigns up and they get reported, we think, well, yeah, of course that happens. HIV is highly stigmatized, as if it's a kind of naturally occurring process. But in fact, brigading is coordinated, deliberate, intended to shut us down, and highly effective in doing so. So it results in our carefully created pages and groups and communities, which often have thousands of subscribers, being shut down, being suspended, and that happening again and again and again. So that was kind of the wicked problem that I wanted to highlight. And it tells us something really valuable about wicked problems, which is that they're not just problems that happen again and again by coincidence. Wicked problems are produced by complex systems of behavior that can reorganize themselves in response to our attempts to intervene in them. So when we face these wicked problems in digital sexual health promotion, we have to always ask, right, what is the system that is producing this problem and what could we do about that system?
Thank you, Daniel. That was excellent and really links nicely to Amy's also reminder to kind of think structurally about how we're engaging in digital and data practices and some of these issues that exist in offline spaces that we consider in our everyday practice and work. We're going to come back around and think about what it does look like to work amongst those challenges and work through some of those challenges. But next, I'd like to invite Jess Wilms, the Aboriginal Health Education Officer at Western Sydney Local Health District. I'm wondering what kind of wicked digital problems you're considering or experiencing in your health education, health promotion role up in Sydney.
Thanks, Sam. I just wanted to acknowledge that I'm coming from Darug land and that I'm a proud Wiradjuri woman. My wicked problem actually feeds really well off Amy's and Daniel's. I think a lot of the same issues face the Aboriginal community as Amy was speaking about for those migrant communities when people don't have access to digital devices and all those kinds of things, and a lot of mob, English isn't their first language, so trying to decipher that information. And when we talk about COVID-19, a lot of that information dissemination in Aboriginal communities was done by Aboriginal health workers. So again, like in that data kind of sphere, a lot of it falls back into that real world and falls onto Aboriginal workforce to disseminate that information, because we can't rely on the digital and data world to do that for us. I guess for me, working in the government, we have a real wicked problem around censorship and policy and procedure and navigating that to get current, like real-time information out to communities that makes sense and relates to communities. I think for health, a lot of our, like, I was laughing when Kath was talking about Facebook, because in my last role, I couldn't even get a Facebook page, and like, how old's Facebook? So the thought of trying to get onto something like Discord or TikTok is just not something we can even have a conversation about, because we are living in the past, and that's what it feels like. And as like someone who sees what's happening, and it's really hard when you work for health, because every health district has different policies and different procedures. So while we all have the same common goal, there isn't an equity across even just the state for us in getting that information out into community. So I think it's about shifting that focus from risk management and worrying about things like brigading and people reporting and all that kind of stuff into how we can kind of, you know, put policy and procedure in place to create safety in a way that we can then disseminate information in a way that works for young people. Because putting it on our, and this is a conversation I literally had like 6 months ago, like putting it on our internet page is not where young people are going to look for information. So we can have the best information in the world, but if you're not providing that in a way that works for communities, and again, it falls back on the workforce, which is a very small workforce in our world, to try and figure out how to do that in a really risk-averse landscape, which makes life really, really hard.
Yeah, so it's not necessarily about this having the skills and knowledge and knowing how to meet young people where they're at. It's about being hamstrung by policy and governance kind of procedures that mean you can't actually engage with that skills and knowledge that you have in order to kind of access.
And not listening to communities, not listening to young people saying, this is how we want our information. The government saying, we know better, this is what you're going to get. And there's just this huge kind of gap between what is needed and what is given.
Yeah, well, thank you for bravely sharing that reflection on government policy and procedures. We're going to come back again, as I said, and talk about what, you know, some of the ways we might work through these challenges. But next, I'd like to invite Melanie, who is a sexual health physician at the Melbourne Sexual Health Centre, to share some of your digital wicked problems from a clinical perspective.
Thank you, Samantha. Thanks for the opportunity to speak. Just to put a little bit of context, the Melbourne Sexual Health Centre is the only publicly funded sexual health service in Victoria, and you don't need a Medicare card to come to our clinic. So we see individuals that come from overseas, either students or just tourists or people just coming to visit Australia and then move on. And our patient population include men who have sex with other men. We have sex workers, individuals involved in sexual assault, vulnerable populations, marginalized populations. So, you know, our main concern from a clinical perspective, and I know Muyi and Kathleen covered a lot of this in their discussions earlier, that, you know, we collate very, very sensitive and intimate information about an individual, and we privy to that information. So we do have a lot of concerns about privacy and security implications of the data technologies and the digital tools that are available, because we collect information about their abortion history, the STI results, contraception use. And then also remember, we have patients from vulnerable populations, patients who come from marginalized populations where there's social determinants of health impact on the ability to access these digital technologies. And so there will be this digital divide where there's inequitable access to these services. So, you know, so this limits the barrier and limits the ability to benefit from these digital health tools. And also we know that sexual health services are very siloed. So, you know, you have sexual and reproductive health, contraception, then you've got men who have sex with men and their STIs and syphilis and pregnancy, etc. So they often operate separately from the general health. And so this siloed, fragmented system prevents a seamless tracking of patients' histories. Even though we have My Health Record, not everyone is subscribed to that, okay? And then we also have the ethical and legal concerns of AI and the predictive and analytics that is associated with AI, because there's lack of cultural diversity in those algorithms. We're also concerned about trust and misinformation, because we use evidence base in our practice, yet these algorithms may not include all of that. And then, of course, we've been working in a clinical setting, and we ourselves as providers may not be completely familiar with how these digital technology tools work. So we also need to train the workforce on digital capability and literacy. And I'm sure we're going to talk about how it affects certain populations in sexual health, so I'll leave it to later. But definitely the most important ethical considerations with data capability is important in our population.
Great, thank you. You kind of started to talk there a little bit about some of the support that you might want in kind of reflecting that. And I'm wondering what it does kind of look like for you to continue to work amongst these problems. What are some of the challenges you might experience?
Well, at our clinic, we've got a dedicated HIV service. So, and I think in our HIV population, HIV positive population, they're already a stigmatized group of individuals. And despite being undetectable equals untransmissibility. So if you're undetectable, if your HIV viral load is undetectable, you're untransmittable. We've got HIV PrEP as a preventative tool. Despite all of this, and which has revolutionized HIV management, we still have a population that's highly stigmatized. So we do worry about what the digital tools might result in, like an HIV data breach or poor anonymization. And this can expose individuals to discrimination, loss of employment, or even violence, as spoke about brigading. And we know in HIV, they have got complex care needs, and we need the digital tools to be able to help track HIV viral loads over time, the HIV treatments that they've had over time, their comorbidities. So these data capabilities and the tools that need to be available have to be robust, they have to be secure, and they need to be integrated. We know that partner notification is really, really important in HIV management and STI management. And we also concerns about, again, data breaches and anonymization. And so we need to be able to balance the public health goals of managing these STIs with individual rights and privacy, okay? And then also we use digital tools to help patients with adherence to medication, because we know that's the cornerstone of HIV functional management and cure. And if we're using these tools like alarms or encouraging people to use certain tools to improve their adherence, would this result in a lack of anonymization as well? So from an HIV management perspective and integrating HIV STIs, again, I think data breaches are our biggest challenge in this case.
Yeah, great. And there's such diversity of digital and data tools that you're using. I think this kind of leads into my next question for Amy really nicely, is like, how do we continue to center equity in these approaches when we're thinking about these problems, and what are some of the challenges of doing that in this work?
Thanks, Sam. Yeah, so one of the sort of tensions of working in this space is, having to juggle the urgency of meeting immediate health needs of a very diverse cohort with differing levels of access and needs, while keeping pace with rapid digital innovation, but still sort of doing the slower yet essential work of driving systemic reform to address deep-rooted health inequity. With the growth of digital technologies, one of the key challenges we face at MCWH is having to combat the overwhelming amount of misinformation that exists, especially online, while supporting migrant and refugee women to navigate often conflicting sources. And, I think it's challenging for all of us, not only migrants and refugees, to figure out what information is reputable, but this challenge can be especially pronounced in the absence of in-language support. Another key challenge is addressing sort of the stereotypes that exist around migrant and refugee women's sexual and reproductive health. And what I mean by that is that there is this common misconception that sexual health issues are too culturally taboo for migrant and refugee women and gender diverse people to engage with, but in actuality, stigma around sexual health exists in all cultures, including Australia's dominant white heterosexual culture. Digital and data technologies don't exist in a vacuum, and we often see these stereotypes being played out online as well. In our work with migrants and refugees, we know that they proactively seek out information about sexual and reproductive health, and they do want the tools and the resources to make choices about their own health and well-being. So we really need to ensure that any improvements brought about by digital and data technologies don't replicate these same societal stereotypes or biases that exist towards migrant and refugee women and gender diverse people.
Great, thank you, Amy. Jess, I think it'd be nice to hear kind of, again, like some of those connections between Amy's sort of thinking and approach and your work, and what it looks like for you to continue to work amongst those challenges, problems.
It's just so similar for Aboriginal communities, and it's so funny because I think the rhetoric is constantly like, we can't talk about sex in Aboriginal communities, we can't like disseminate information, and you look at things like Take Blacktion, which I'm a part of, and that's not true. It's just about how we deliver the information in a way that works for community. And I think continuing, I guess I can see that like Maddie Stratton's on this Zoom as well, like workers within our space just need to keep advocating for better access and better, I think a commitment from the government to do things better and to do things in a better way that works for communities. And I think, when I get asked to be part of this research, that's one of the motivating factors for me to say yes, is for me to put our foot in the door as a collective and represent my workforce, and to then take this back to them and say, this research is happening, like how do we work from that and use this as a leveraging tool to show policymakers that this is where it's at and this is what we need. I think that's kind of how we need to do it. And I think it's about inviting you to speak and inviting people that have that knowledge to speak to the people that make decisions and show them that this is what is necessary. So I want to thank you and Kath and everyone involved, because I think I was so excited when this came up, because it's something that we constantly speak about but never have any data to back up what we're asking for.
And thank you right back. Jess has been one of the biggest cheerleaders of this work over the last nearly 4 years, which leads nicely into Daniel, who's also been a big part of the project. And I think, Daniel, going back to brigading, I'm wondering, is this something that should be is brigading something that should be keeping up, organizational managers and leaders awake at night?
Okay, so I'm a chronic insomniac, and therefore I promote and encourage good sleep hygiene for everyone, including the managers and the leaders of our organisations. But with all that extra time I have at night when I'm not sleeping, I spend a lot of it worrying about how practices like brigading affect our social license to operate in social media spaces, and what you might call the headroom available for us, the kind of ever-shrinking space for us to do sexual health promotion that is innovative, that is frank, that is sexy, that is funny. And Jess just gave the really great example of Take Blacktion, which is the perfect example of the kind of campaign that I have in mind, that was funny, a little bit risque, had enormous social, cultural capital. And when we have these practices like brigading that put our pages, our subscribers at risk, that's a threat to our ability to do the job. And that's not just a matter for risk management or digital strategy. That's an existential threat to our organizations and our ability to do the work that we do. And to really kind of highlight that, I just want to note, many organizations have stopped doing any kind of outrage there's a Freudian slip. They've stopped doing any kind of outreach except via social media. So we don't do the face-to-face events that we might once have done. We may not emphasize or rely on newsletters the way that we used to. It's entirely premised on having access to platforms that are now really hostile to the work that we're trying to do. So yeah, I hope they sleep well at night, but I do hope that over their morning coffee, our managers and our leaders are thinking about how did these trends affect our social license and our existence as organisations.
Yeah, super important things for managers and leaders to be ruminating on and thinking about how they can support their staff to kind of think about these things as well. I think at an organisational level, rather than just sort of leaving it up to hoping these things don't happen. And again, want to flag Daniel's excellent blog post that Caitlin has put in the chat, where Daniel referred to the campaign as something that would be acceptable by bed threads, which I think is a great way of framing that. I'm mindful that we're going to leave 5 minutes at the end of this chat for audience questions, but also perhaps questions amongst the panelists. So I just want to quickly go around maybe with a couple of word answer to thinking about what kind of support the SRH sector needs, organizations, practitioners, etc., need to deal with these challenges. If can be big pie in the sky kind of reflections, or it can be something quite obvious, which you may have already touched on. So Melanie, I can see your mic's off. Let's go with you first.
Well, I think that we have to work across all stakeholders. And I think the most important thing is to ensure that we have permanent ring-faced funding, because we can't actually work on things if we're not having an ongoing budget for it. And I think that we need to have both national and global standards, so that, and these are embedded in the technologies. We also need to train our workforce. Any of us dinosaurs who have been working for a long time, we may not be completely familiar with how these technologies work. We need to have good infrastructure with good privacy within the infrastructure. And I think it really needs to be community-led. Not just as Muyi and Kathleen spoke about, it needs to be from a grassroots level, asking individuals what they want and then integrating it with across the sector.
Great, thank you. Daniel.
So in the blog post, I used the digital and data capabilities model, and I kind of highlighted, obviously, the issue I've raised is a question of governance, but within that, it's also a question about how we access the lived and living experience of people who are making their living in social media spaces at the margins of those spaces. So sex workers, porn consumers, people who use drugs, people with mental illness are all the experts in how to kind of find what you need and maintain your presence in very hostile social media spaces. So that would be my kind of tip on how we can do this, and also what is the value of the digital and data capabilities framework.
Great, thank you, Daniel. Jess?
Yeah, I think community consultation, having a really big commitment from government, especially in my case, in figuring out what we need to do. And I guess following on from Melanie, like funding, you can't do anything without money. You need to train your staff. We all need to be skilled in how we collect data, how we analyze that data, and how we use that to disseminate information in a really useful, and I guess it always comes down to dollars, so making it a cost-effective campaign for us.
Great, thank you. Amy?
I think we need a second panel to really unpack this question. But to keep it short and succinct, I think, our work sort of needs to be guided by a broader vision of creating an equitable healthcare system. And as the other panelists have alluded to beautifully, to do this work, we really need to centre the voices of lived experience. And specifically for us, it's migrant, refugee women and gender diverse people, not only in conversations around digital and data technologies, but in pushing for long-term structural change. And this could look like, co-designing digital health and data initiatives with migrant refugee communities, resourcing organisations with health expertise to produce information in multiple languages and formats, partnering on community-led research, but lastly, also advocating in policy spaces to ensure that digital health strategies don't leave migrant and refugee communities behind.
Great, thank you. All right, this could, as Amy said, keep going forever, and I'm really loath to sort of cut the conversation off, but I want to give us a couple of minutes to see if there are any questions from the those in the Zoom, or if anyone has any questions for each other. We've got about 3 minutes, but we will come back at the end. So are there any questions? Did any of the panelists want to ask a question of each other? No. Okay. Well, I think maybe we'll wrap it up now, because I actually have a lot of questions, but they need more than a couple of minutes to ask. So I'll save them for the very end. And I want to thank all of our panelists very, very much for such a fruitful and productive discussion. And I'm very sad to cut it off. So hopefully if there's any questions ruminating in the Zoom, please get them ready. We're going to have about 15 minutes at the end to ask questions of each other. And I think we should be very grateful for the expertise we have right now, and kind of get as much out of it as we can. So thank you very much, everybody. I'm going to get out of the way and hand over to Kath again.
Thank you, Sam. And yeah, thank you again to Muyi, to Jess, to Amy, Daniel, and to Melanie, because as Sam said, practitioner perspectives have been at the centre of this project, but also I think are at the centre of what probably needs to happen in the next steps in terms of interdisciplinary digital health research, where we work with communities, but also we work with the sector to hear about what works and what doesn't in the more holistic ways that we might engage with digital technologies and with data practices, from a consumer perspective, but also from a kind of workforce perspective. And I know many of my colleagues in the ADM+S are very engaged with these questions. Okay, so this is the part of the process where we talk about what we did in the actual research project and how we did it. I want to say I am so incredibly grateful to Sam for being my colleague and collaborator on this project. I could not have done it without you, Sam, and your incredible practice experience, and also your incredible theoretical and conceptual insights into the questions that we were asking. I'm going to take us back through to the project aims that I drafted in the grim, dank darkness of the 17th or 18th Melbourne lockdown back in the day, where I pitched this enormous project, where I said I was going to analyse the role digital technologies and platforms played in the everyday sexual and romantic lives of a priority population, let's say it that way, young adults, map and benchmark digital literacies and data literacies in health promotion and clinical service provision, and then develop new theoretical and applied models to guide policymakers and practitioners. It sounds like a lot. I think we actually had a pretty good go at it, which is amazing. So thanks, Sam. I'm going to talk a little bit about what we did and how we engaged with participants and practitioners and health consumers at every step of the project, because this is the element that I know Sam and I are most proud of in this project. It is a very interdisciplinary project. You can see on the far right-hand side of the slide this is the range of disciplines that we drew on to conceptualize this project. And what's not there is adult education theory, which we and critical pedagogies, which we also engaged with as part of this project. It was very broad scoping, and as you can imagine, there were some struggles in bringing the threads from these different disciplinary approaches together, and building a website to express all of this when you have no experience with developing websites or user experience work. Who knew that would be hard? We certainly didn't. We did it anyway. We worked with a range of incredibly generous health promotion and clinical practitioners and policymakers and researchers in this project. And we also worked with a great peer research team of young researchers aged in the 18 to 29 group, who conducted really interesting and informative research workshops with young people who use technology to support their sexual and reproductive health. And I'd like to give a special shout out here to Transgender Victoria, and they partnered with us on specific workshops for the people in the health consumer group who expressed a preference for a trans and gender diverse only group. And we had peer facilitators and researchers leading that project too. So thank you very much, Transgender Victoria, for guiding us and both helping us think about how gender health might be something interlinked but also distinct from sexual and reproductive health, which was really important for our thinking on the project, and also to the workforce from Transgender Victoria. And thank you, Son Vivienne, the CEO of Transgender Victoria. Thanks, Sam. We'll go to the next slide. So we had a range of data collection methods. We undertook a narrative literature review very early in the process, looking at the ways that sexual health research and public health research used the terms or defined the terms digital literacy, digital health literacy, and how those terms were considered in the light of sexual and reproductive health. Because we were trying to think about what digital literacy meant for the workforce, we were really curious to see the ways that the research space talked about these terms. And what we learned was that digital literacy and digital health literacy are two terms that are used quite a bit by academics and practitioners, but are very poorly defined within the literature and very vaguely defined within the literature. So there's Skinner's definition, which Muyi shared earlier, but that's a definition that applies to health consumers. Most of the definitions applied to health consumers. And as I said, this is a cross-disciplinary project. Obviously, there is a history of thinking about literacy and the meaning of literacy in the humanities and social sciences. And one of the things we found when we went back to that literature is there is an acknowledgement in that space, as there is in the space of critical health literacy. There is an acknowledgement that the term literacy is not a neutral term. It can often be a moral term, and it can be used to imply a deficit in those that lack literacy or have not yet attained measures of literacy. And in the workplace, and thank you to my colleague Anthony McCosker for sending me to Annette V's work about coding literacy and the history of learning to code as a valuable workplace activity. There are certain kinds of literacy in work that are considered to be literacy, and there are other kinds of workplace skill that are not considered to be literacy. So Annette V says, you know, we never talk about the barber being hair literate. We never talk about the mechanic being car literate. And yet those of us who are kind of knowledge workers, we have literacy. And V talks a lot about, in a long and complex book that is very much worth reading, about the ways that we can understand literacy as a concept that can, if it's not very carefully applied, reimpose hierarchies about the kinds of knowledge we really value and the kinds of knowledge we don't in specific cultural contexts. Anthony had been doing a lot of work on this in various projects we were collectively involved in. And when it came to this project and thinking about how we were going to define digital literacy and data literacy, we followed the work that Anthony had kind of pioneered around data capability and decided we would also adopt a capability approach. And in terms of capabilities, we're drawing both on a kind of understanding among our colleagues in the field of computer sciences, that when we talk about capabilities, we're talking about not just the humans, but the infrastructures and technologies that we are working with, but also looking at health economics and international development and the work of Amartya Sen and Martha Nussbaum, where they talk about capabilities in terms of agentic capacity. And we really wanted to foreground that kind of strengths-based and equity-focused approach in this work. So health literacies became health capabilities, digital literacies became digital capabilities in this project. And we worked to develop both a set of models that mapped out different areas of capability, and then to sense check and validate those models with the sector. So in stage one, as we came to develop the models and the website, we asked the questions: how are digital and data literacies defined in existing public health literature? How are they defined in policy and practice? And what might the best models be for the health workforces? And we talked to some incredibly expert key informants. We synthesized that literature. We went back to our expert reference group, and we developed the models that I'm going to show you now and that you can read in our report or see on the website. So the first one is the digital capabilities model, which addresses 3 areas of capability, including access and infrastructure. And that's on a really, prosaic level, as Daniel said, whether or not your Zoom drops out while you're trying to give your webinar. Skills, and then also the question of governance. The second area of capability that we've outlined via a model, which I'll just ask Sam to flick forward to, thank you, is data capabilities. And this is drawing on the data capabilities work that Anthony led and that I was part of, working with the not-for-profit sector here in Australia also. So we developed these 2 models in the first stage of the project, but we also wanted to work now with health consumers to think about what these capabilities would look like from a consumer perspective. And I'll hand over to Sam to talk through that stage of the work.
Thanks, Kath. So I guess in thinking about our consumer perspectives, we were really guided by this question of, and as Kath has said throughout today's session, we thinking about consumers in the terms of young adults. So that meant aged 18 to 29. And so we were really curious to find out what young adults wanted health professionals to know about their digital and data practices as they related to sexual and reproductive health. So we did this via 8 workshops and 2 interviews. And what we found was that young adults, to no one's surprise probably, is that young adults have really strategic digital practices that support their sexual and reproductive health in diverse ways, thinking about different kind of needs, different identities, different practices and things like that. And that these digital cultural practices support their offline health seeking behaviors. so can support how they approach a clinical interaction. They can do some research to find out how can I ask a question to get the kind of support that I'm looking for. And it also fills a gap in kind of existing healthcare needs, whether that's education or whether that's feeling like you've been dismissed by a health practitioner in the past, and so you're looking for further support. And so what they really wanted was for health practitioners to not dismiss these practices, but to really understand and respect them. And that didn't always mean that they wanted health practitioners to be present in their digital spaces, whether that was not always kind of considered ethical either. But it was really about kind of not just dismissing them. If I went to a clinical appointment and I said, I found this information online, it doesn't mean that that is automatically dismissed, but I'm listened to because I've done some research and I've got these concerns, is one example of what that might look like. So one of the outcomes of that work was the development of the consumer model, which sits alongside the digital and data capability models that Kath just shared, and I'll show that in just a second. But what we also found in this stage was that it was actually quite hard for our young adult participants to imagine how their experiences could support the digital and data capability building of a health sector when they didn't really understand the behind the scenes or the black box of healthcare. And in those interviews and workshops, we did have some young people who were also practitioners that were able to offer some additional insight into what that might look like. So we ended up facilitating another round of workshops and interviews with young adults who were also sexual and reproductive health practitioners. And we asked the questions around thinking about resource development. So we focused on looking at how the models and the draft resources that we'd come up with could support the current workforce. And what we found was that the models provided a shared vocabulary for critical and strategic conversations across different elements of the sector. We found that I'll talk a little bit more about those findings in a second. And that led to how we developed the website, which we talked about with our reference group. And I'll again show you that in a second. We just wanted to flag some of the key publications that kind of sum up a lot of that work because we're going through it quite quickly now. So we've got our stage 1 and stage 2 reports and 2 articles looking at the digital determinants of health, and also thinking about what Kath was talking about, that kind of change from looking at digital literacy to considering a capabilities approach. So there's more information about that there if you're wanting to find out more. And we have a couple more coming soon, we hope. So this is the consumer capabilities model, which I just mentioned before. And this was really designed to help the sexual and reproductive in response to what our young adult participants shared, is really meant to help the practitioners and organisations understand the many strengths sexual and reproductive health consumers have when it comes to their digital and data practices, and how these practices do shape their sexual and reproductive health. So it's not necessarily about how we can improve the digital literacy of young adults, but it's about considering from a strengths-based perspective, the consumer practices. So thinking about what we were talking about before, it might be a way for practitioners to embed lived experience, or to consider how to embed lived experience in their digital transformation, in the way that they're engaging with digital technologies and things like that. So questions like, what are digital sexual health technologies? As Muyi said before, it's not just about the ones we consider as technologies that we've designed specifically for sexual health, but it can be things like Facebook, social media, LinkedIn, even things like that. So when it came to our second round of interviews, we really wanted to find out what the resourcing priorities of the sexual and reproductive health sector were, so we could best support them through how we developed the website and additional resources. So what we found was there were differing needs across the sector, as is evident in our conversations today, and also within individual organisations. So while some participants really would have liked a taxonomy or a checklist that kind of stepped through what they needed to do in order to kind of build capability, others really wanted a more discipline agnostic approach. But what we did find were some common concerns. So participants described, particularly post-COVID, a sector that was quite burnt out and very under-resourced. This was particularly felt in more rural areas who described health promotion officers as kind of being alone doing a lot of this digital work, not having access to communications staff or greater support to think about how to do digital health promotion outreach or engage with digital technologies in other ways. So we also had, overburdened and time-poor staff engaging with digital and data technologies in ways that was beyond their expertise. So they really wanted further support for their organisations to better understand the specific expertise, training and policy that is needed to kind of work in digital spaces. We also found that younger staff who are often assumed to be digital natives, that is, because they've grown up with technology, there is an assumption that they just know how to use it, are often kind of delegated the day-to-day and strategic work of digital health, regardless of whether they have had specific training or have any expertise in that area. And our participants also reminded us that it was really important to recognise that there may be resistance or shame around an inability to engage with digital transformation. And so a strengths-based approach was seen as a way to kind of really reframe that. When it came to actually designing the resources, our participants talked about, again, being time-poor practitioners and really wanting to be able to engage with materials at their own pace. So for some, that was sort of bite-sized chunks of information that they could dip into when they had time, or as one participant said, when I'm on the bus, I can open it up and read something brief that will help me engage with this topic. But I'd also like to be able to access further information if I needed it. So it was about having different levels of information that was accessible at different times and when there was different ability to have the space to engage with these things. They also shared with us that it was important for our models and other kind of associated resources to also link out to external government policy guidance and strategies and things like that, as a way of making this both meaningful for, and I guess not necessarily meaningful, but sort of giving it some weight for leadership and management. So if the government is coming out with these strategies, then we need to be ahead of the game, and we should also be thinking about what this looks like. They wanted web-based information that they could access, again, as I said, when they were able to, but also with standalone PDF downloads so that they could take it offline and read it, or that they could put it, print it out and put it on their walls. And above all, we didn't want boring beige-coloured resources that were sort of hard to engage with. So what did we do? We ended up designing our website. And as Kath said, neither of us have designed a website before. We worked with a digital media producer, Sadel Sadana, who helped us come up with this website. What the insights shared with us kind of told us is that what is needed is not necessarily a one-size-fits-all approach or a structured curriculum, but rather a suite of resources for time-poor professionals who need to adapt really quickly, often with very little time, to new technologies or digital transformation on the run. And as Kath mentioned before, we really drew upon adult education theories. So thinking about, stemming from the work of Freire to now thinking around Jack Mesereau and Stephen Brookfield, to be reminded that professional development is embedded in the existing knowledge and practices and experiences of practitioners as well as their organizational context. And that means having access to resources and infrastructure, but also organizational culture and support. So what we came up with on the website is a bit more of a choose your own adventure activity. We have discussion prompts and case studies which are drawn from the research that help people, help practitioners, help managers, help leaders step through some of the capabilities and think about how it might be relevant to their own organization. We have a hot topic section, which again is drawn from our engagement with practice and practitioners and thinking about some of the issues and some of the wicked problems that came up in these conversations. And the overall aim is to kind of promote critical conversations and reflections in a workplace, in the organizational setting, in a way that is relevant to each organization. So as part of our sort of iterative approach to that, we also engaged with our reference group and took the first iteration of the website to our reference group. And we had some really great feedback around that, and we kind of rejigged it to be a more pedagogical approach, helping people walk through the website in a way that was relevant to them. And Kath's going to tell you how that was received.
Yeah, thank you. So in the final stage of the work, we undertook what's termed construct validation or critical construct validation, which is a qualitative practice. The term comes from psychology, but it's used in feminist action research to think about not just whether the terms make sense to everyone in the kind of classic validation sense of a kind of health validation, a health tool validation, but to also interrogate the central terms. So when we took the website out to trial it or pilot it with very generous practitioners and people in the sector, we were really asking them to unpack the central concepts and the models and ask us whether or not they were valuable and meaningful for them. We had very supportive feedback, but also some really honest feedback about the limitations of the work. And we have shared that in the model. And we also have shared that information in the report. So we invite you after this launch to go and have a play with the website. It has many, many resources embedded in it. It is designed to fit your purpose. It is developed as a kind of knowledge translation exercise for our research, but also as a living document that can evolve as situations change and more issues come up for the workforce. So I would really love to hear from practitioners about how the site is being used or not being used and what might happen next. So that is the project as Sam and I were most centrally engaged in it, but I would now like to introduce a fantastic application of our thinking around digital and data capabilities, drawing on critical data studies and a range of other interdisciplinary approaches. Caitlin Learmonth is the PhD student candidate, very close to completion now on our project, and it's an absolute pleasure to introduce Caitlin to talk through her side of this project. And I think, you know, it has some really interesting and very important resonances with the practitioner panels we saw earlier today, as well as with academic work in this field. Thanks, Kate.
So much, Kath. I'm going to start myself a timer and try very hard to speed run my PhD in 10 minutes. But I'd like to start by acknowledging the traditional owners of the land where I live and work, which is the Wurundjeri people of the Kulin Nations, and extend my respect to the traditional owners of the lands across which my research has taken place across Australia. And this always was and always will be Aboriginal land. Sam, if you could go to the next slide for me, please. Perfect, thank you. So as a brief background to my PhD research, I use consensually non-monogamous sexual health consumers as a study to consider how the digital and data practices in primary health settings impact the delivery of clinical sexual health services for consumers falling outside of normative data binaries. So I'm interested in what the digital and data practices that shape clinical service provision are, how consensually non-monogamous consumers challenge these infrastructures, and what the digital and data capabilities are of both sexual health consumers and healthcare providers to access and provide clinical sexual health services. So to do this, I have listed this off, but I first did a policy review of all of the clinical guidelines that guide sexual health service provision and digital and data capability frameworks that have recently come out from the Australian government. I conducted interviews with 17 consensually non-monogamous sexual health consumers, and I then sense-checked these interviews with some healthcare stakeholders, and then further conducted some workshops with a broad range of healthcare stakeholders, including people in clinical roles, health promotion, training, policy, and research, to really get a gauge of what digital and data capabilities look like across the broad spectrum of sexual health service provision. Next slide, please. Thank you. So just as a brief overview of the rationale behind using consensually non-monogamous consumers as a critical case study, this is just some of the terms that my participants use to describe their relationship and partnership types, but it broadly covers people who have multiple and concurrent partnerships. This is a recognized practice in some current high-risk populations. So, for example, gay and bisexual men who have sex with men, and young people are considered to have multiple concurrent partners or multiple casual partnerships, but as a standalone sexual subculture, it's not currently recognized within priority population or risk frameworks. And I should emphasize that I don't necessarily advocate for consensual non-monogamy to be included as a high-risk population, but I just think it's interesting reflection on behavioral assumptions and how we apply risk frameworks for clinical service provision. And consensually non-monogamous sexual health consumers are an interesting case study because they engage in a lot of practices that are typically deemed high risk, that aren't currently accounted for in sexual health databases. And as STIs continue to rise across Australia in both high risk and non-high risk populations, I think it's important to consider sexual subcultures outside of current risk frameworks. And when I interviewed consensually non-monogamous sexual health consumers, they highlighted frequent and asymptomatic testing and comprehensive testing as standard for people not currently identified as high risk. Next slide, please, Sam. So through my interviews and consultations with healthcare providers, I found a range of digital and data frictions that impact the provision of clinical sexual health services. So a big one was a disconnect between clinical guidelines and public health rebates through Medicare. So, for example, current STI management guidelines recommend asymptomatic testing for any patient who asks for it. Medicare only funds one full screening per year for non-priority populations. And the data input options on clinical decision support systems used by healthcare providers to process clinical services also had limiting options for being able to provide these services. Many of the digital health systems that are used in Australian primary healthcare settings are proprietary, and there's a significant lack of interoperability between these systems. It was also mentioned earlier in one of the panels, there's been a relatively limited uptake of My Health Record for a variation of reasons, meaning that transfer of information for patient history between healthcare providers is quite lacking. And sexual health currently isn't covered by data standards that are used in primary health setting digital systems. And there's a range of inconsistent data practices and capabilities between healthcare providers, largely around how they input information, how they determine what information is clinically relevant. And in specialist settings that use pre-screening, digital pre-screening mechanisms, there are limitations in accounting for risks associated with extended partnership networks. I have an example here, but I'm already at 5 minutes. So Sam, if you could go on to the next slide. Thank you. So as a result of the digital and data frictions experienced by both healthcare providers and essentially non-monogamous healthcare consumers as they try to access sexual health testing, the consumers engaged in a range of strategic practices to be able to access more frequent asymptomatic testing and more comprehensive testing. One of their main strategies was using multiple services to fragment their data and avoid flagging over testing. So they would use bulk billing general practitioners and online services generally for asymptomatic testing. They would go to their regular general practitioner if they felt that they were symptomatic, and specialist services if they were accessible to them. The use of online services was also strategic in terms of being able to bulk buy pathology scripts. So one service that was used by a lot of my participants, you can buy up to 5 pathology scripts and use them at any point. And also the ability to share results within those sexual networks. Some of my participants saw this also as a strategy to relieve pressure on in-person services, knowing that they were testing asymptomatically. And they would also indicate higher risk. So they knew how to associate themselves with high risk populations to be able to access more comprehensive testing. Next slide, please, Sam. Thank you. So there was a range of data frictions that are identified by my healthcare provider participants. And a big one was around the tension between data inaccuracies, epidemiological targeting, and the funding of health services. So if healthcare consumers are misrepresenting themselves as higher risk, then it skews the epidemiological data. But it also has an impact on the targeting of health promotion as well, knowing which populations need targeted health promotion. But healthcare providers also acknowledge that they have to skew the data themselves to be able to process clinical services, particularly around Medicare billing codes. And this friction was particularly complex in terms of providing continuity of care and patient-centered care. There was also varied digital and data capabilities between practitioners and organizations, as I mentioned earlier. So digital frictions and variability in practitioner capabilities, in between practitioner capabilities impacted what data was inputted and how. And this was further exacerbated by multiple service use by consumers, which meant that their data was highly fragmented, even if it was shareable between health services. And this is particularly acute problem for contact tracing, particularly for contact tracing where there was movement between different states across Australia. But healthcare providers generally also understood why healthcare consumers would fragment their data as a protective practice. And there was some tension between the need for interoperability for continuity of care and patients' right to fragment their own data. And then just my final slide, please, Sam. Thank you. So implications of my research ongoing considerations is thinking about who benefits from interoperability. So it's obviously beneficial for clinical continuity of care and patient-centered care between practitioners and their patients. But there's complexities around data privacy, particularly for sensitive issues like sexual health. And the need to standardize data for it to become interoperable, it creates complexities for representation. There's obviously significant implications for service targeting and funding where data is being misrepresented and ensuring that services aren't limited or taken away from high-risk populations. There's a considerable risk of asymptomatic overtesting by this group of consumers, particularly through their use of online services. And there was an awareness of overtesting among both my consensually non-monogamous participants and healthcare providers. And the role of online testing services is equally as complex. They are seen as a tool to take away or relieve pressure from in-person settings, but they're also currently not regulated in Australia. So a key question is how we move towards equitable patient-centered care in a digital and data-driven era for healthcare provision. And then just my final slide, Sam, just to say a quick thank you to all of my participants who took part in my research, to my wonderful supervisors, Kath and Anthony, and the fellowship that we're presenting today that I'm funded under, and to the Centre of Excellence for Automated Decision Making and Society for their research support and funding. Thank you.
Thank you, Caitlin. That was so fantastic. And I know it is really hard to rattle through your whole PhD in 10 minutes, but it's such an important project. And from a proud supervisor perspective, I would like to, share that Caitlin's work is already having policy impact here in Australia and has had some interest internationally. And she's doing tremendous work that I think is really helpful for moving forward in understanding the role of data collection practices as well as data collection technologies within digital health and sexual and reproductive health particularly. And we know from our colleagues at Transgender Victoria that the same kinds of strategic code switching to access healthcare is certainly something that our trans and gender diverse colleagues and siblings and friends are doing, because if you know that you need a particular kind of healthcare, but the correct tick box isn't available on a data collection form to make yourself visible in a way that is important to you, you will simply tick the expedient box that makes you legible to the healthcare services in the ways they want to see you. And while that is practical and strategic, it doesn't actually give you the kinds of really equitable healthcare systems that you need going forward in the future, including data systems, but also systems of care. So Sam and I are going to wrap up now before we go to question time. I just wanted to reflect that we are incredibly grateful to the funding that we've received from the ARC and the incredible support that we've received from the Centre of Excellence for Automated Decision Making and Society. My fellowship is actually active until the end of January 2026. So this is not the end of the work or the project. It's just that Sam will be heading on maternity leave in about 10 days. And so we wanted to make sure that we could launch the work properly before she moved to the next exciting project. One of the things you may have been wondering earlier on when Daniel was talking about brigading is, okay, this is great. And someone asked me this from a health organization recently when we were talking through the models. These models and questions are very good for identifying problems that need attention in my organization. What are the strategies for actually addressing these problems? We're really pleased and proud to be doing some funded research now in direct collaboration with the National Association for People with HIV through the Swinburne Social Innovation Research Institute that will work on developing some really good evidence-based and also practitioner-led guidance around how to develop resilient community connections in digital platforms and technologies that are getting increasingly hostile. And the first stage of that work obviously focuses on the HIV positive community, but we're hoping to partner with other organizations down the track and think more about, okay, what's next when we begin to identify these problems? What can we do to actually solve them? And my excellent Swinburne colleagues are involved in that project. Sam, is there a final reflection you'd like to make before we move into questions and comments?
I think it's like part of the joy of working on this project, aside from working and learning from you, Kath, is the sort of the challenges and the benefits of interdisciplinary work, and really being on a project that frames it as such is really rewarding, given that I have also personally got kind of an interdisciplinary background. And I think one of the things that has been enabled by the fellowship funding and the approach that you designed back in the doldrums of COVID is that we were able to be responsive to the needs of practitioners, and change the project if we needed to accordingly, and bring that into dialogue with really different theoretical approaches. And I think that's being both one of the strengths and one of the challenges of the project. So that's probably something I'd like to finish on.
Yeah, definitely. Thank you. We have just a couple of minutes for any final questions or comments. We have a thank you slide to put up while people are collecting their thoughts. If people don't have questions now, but would like to get in touch in terms of follow-up or potential collaboration in the future, particularly while I'm still funded in the next few months to be doing this work almost full time, we would really love to hear from you. And the report is live on the Analysis and Policy Observatory, and you can also visit the project website at your leisure.
Also, just another thank you to all of our speakers who shared their time and expertise with us this morning. We're very lucky and grateful to have had your excellent reflections.
Yeah, and thank you for our critical friends, some of whom are here, some of whom are not here, but all were really frank and happy to tell us we were doing something wrong when we were, and happy to steer us on a corrective path. And we're very grateful for that too. Couldn't be more grateful for that level of respectful collaboration.